Now, crying and fussy behaviour is a common behaviour in infants, but occasionally there are underlying issues such as a cow milk protein allergy or maybe even gastro-oesophageal reflux, also known as GORE. Now, paediatrician Dr. Maria Menkins is here to talk to us about the causes of cow milk protein allergy, treatment options, and will provide you with some strategies to help manage this. Now, it's my pleasure to welcome Dr. Menkins.
Thank you. Hi, everyone. I'm Dr. Menkins. I'm one of the paediatricians at Greenslopes Private Hospital, and I'm going to give a brief overview today on food allergies in children. So just an outline, we'll start off with a few definitions. We'll look specifically at the most common food allergy that occurs in infants, and that's an allergy to the cow milk protein. We'll have a look at common allergens seen in toddlers, how to manage food allergies from infancy to school age, and then if we've got time, we'll have a look at food refusal in children. There'll be time for questions at the end, but probably not that much. But I'm over at the Greenslopes maternity section, so if you've got any questions afterwards, come and have a chat to me. So firstly, what is a food allergy? Well, it's an adverse reaction triggered by the body's immune system to a generally harmless substance within a food, and that allergen is usually a protein. Now, there are two main types of reactions that we see, and this can get a little bit complicated, but we see either an immediate or a delayed type reaction, and we call the immediate reactions an IgE-mediated allergy, and the delayed type reactions a non-IgE-mediated food allergy. Now, food intolerance is a bit different to food allergy. It's different in its mechanisms, it's different in the way it's diagnosed and managed. So we'll have a look at this definition as well a bit later on because it's quite important. So I'm not sure how well this projects, but an IgE-mediated food allergy occurs where an allergen, such as a protein, enters the body and an antibody develops, an IgE antibody, that recognises this protein as foreign. It binds to the protein and then binds to an immune cell in the body called the mast cell, which actually then breaks down and releases chemicals such as histamine, which cause the reactions that we see in the food allergy. Now, the thing about an IgE-mediated food allergy is that it's immediate in its onset, okay? So it usually occurs within minutes to hours of the protein or allergen being ingested. The non-IgE-mediated food allergy is not so well understood, but it is mediated by the immune system. It doesn't involve the production of IgE antibodies, but sometimes other antibodies are formed. The symptoms in your non-IgE-mediated food allergy are usually isolated to the skin and or gut. And so we typically see vomiting, diarrhea, poor weight gain, abdominal pain. And these symptoms, as I mentioned, are delayed in terms of their onset to either days to hours. Hours to days, sorry. Now, I don't know how well this projects either, but with your food intolerances, they're different in that they don't involve the immune system, okay? So a way of thinking about this or the other mechanisms that are involved are things like a pharmacological reaction, and some of you may have had a reaction to caffeine with nausea or a headache, so it's a pharmacological reaction. It can also be a metabolic response. Some of you may have experienced lactose intolerance, and that's where you have a deficiency in the enzyme lactase, so you aren't able to break down lactose in milk, and so you can get symptoms associated with that. So it's not involving the immune system. And another example is food poisoning, which is a toxic reaction, so it's quite different. To have a look at cow milk protein allergy, which is the most common food allergy in young children, it's seen in around 2 to 3% of infants, so that's under the age of 12 months, and about 1% of children who are above 3 years of age. The proteins responsible usually are casein and whey. The symptoms usually are seen in the first few months of life and can be seen in exclusively breastfed infants where the mums ingest cow's milk in their diet, or often in formula-fed infants. And the reaction that occurs is either IgE-mediated, so immediate in its onset, or non-IgE-mediated or delayed, okay? And sometimes there can be a combination of the two. How does it present? Well, the immediate type presentation is with either hives, wheeze, sometimes vomiting, facial swelling, and rarely anaphylaxis. The non-IgE mediated usually presents with gut symptoms. So the infant may present with vomiting and diarrhea if the small and large bowel are involved, or with a bloody diarrhea if just the large bowel is involved. Obviously, they can present with some skin symptoms, weight loss, failure to thrive, and there's a small subpopulation that can present with infantile colic and constipation. So you have to be aware of this and think of these things. So can we test for it? There are skin and blood tests available for your IgE-mediated cow milk protein allergy, but as most babies present with the other form, it's really difficult for us to test for this. We can do stool testing in a baby who presents with bloody diarrhea to look for blood in the stool, but usually we rely on an elimination diet for the diagnosis. So that involves 2 to 4 weeks of dairy exclusion. So in a breastfed mum, she goes on a dairy exclusion diet, and in an infant who is formula fed, we look at formula alternatives. So before I slip to the next slide, does anyone know some of the formula alternatives that we have? No? That's okay. I don't know how well this projects as well, but it just shows quite nicely that the protein in your cow's milk, in the infant formula alternatives, it's broken down to varying degrees. So you can get some over-the-counter formulas such as Caricare HA, Aptamil HA, Nan HA, and they're your partially hydrolyzed formulas. So the cow milk protein is partially broken down in these formulas. And they may be enough to help the symptoms in your child, but often they're not. And you need the protein broken down even smaller, sometimes even to the point that it's broken down into its building blocks, which are the amino acids. So your extensively hydrolyzed and your amino acid formulas actually are only available on prescription. So you need to see a doctor, usually a pediatrician or a gastroenterologist, to get these formulas prescribed. Other formula alternatives, and I thought someone might mention this, is your soy formula, okay? So not recommended for infants under 6 months of age, but for infants above 6 months, it's a good alternative because there are lots of other solids that are available with the soy. Just remember that there is a cross-reactivity between the protein in soy and the protein in cow's milk in 1 in 5 children, so you have to be aware of that. Interestingly, goats and sheep milk is not recommended. A lot of people aren't aware of this because they have the same protein or a very similar protein, so almost 100% cross-sensitivity. Rice, almond and oat milk are also formulas used by people, and again, they're not recommended, especially in the littlies, can be used in older children, but they do lack essential proteins, vitamins and minerals that are required in the diet. So in a child whereby they may be on rice formula, they should have additional servings of protein and things like that, and often you need a paediatric dietitian involved. So looking at the older age groups then with your other food allergies, well, 90% are caused by this list here. So cow's milk, egg, peanut, tree nuts, fish, shellfish, soy and wheat. Now, we've kind of talked about the symptoms of your immediate onset food allergy, and they affect 4 main organs. The skin, obviously, with your rashes, your hives, your swelling, the gut, ranging from an itchy mouth to vomiting, diarrhea and tummy cramps, respiratory symptoms such as cough and wheeze, and very, very rarely the cardiovascular system can be involved with low blood pressure and very, very rarely collapse. Most reactions, as I've said, are mild to moderate, okay, and usually involve the skin and gut. And usually you will have a presentation of a child with skin or gut symptoms before they get the more severe symptoms involving the lungs and the heart. So what do you do if you think, oh no, my child has a food allergy? Well, obviously you should avoid the suspect food until medical advice is obtained. And it should be a priority that you seek medical advice in this instance, okay? It's very helpful if you come to see us with a food symptom diary, and I'll put up an example of that. But, so you document any foods ingested and try not to be biased about this. Often parents are really good because they know their child, they know what foods they've eaten, but try not to be biased. It may not be the peanut butter on bread, it may be the sesame seeds, okay? So it's important to document everything that's ingested in your child's diet, the type of reaction that occurred, how long that reaction lasted, so the time between ingestion of the food and then the reaction actually occurring, and then what medication was actually administered, what medical help was sought, and then what the reaction to that medication was. So all that can be very useful when you come to see us. Photograph any rashes. People are great at doing this these days. You know, you might not know what hives is or a dermatitis is, but just photograph the rash and bring it in. Family history is also useful, okay? So this is an example, again, I'm not sure how well it projects, of just a food symptom diary. And you can see, if you can read this, in this particular child, it was the first time that they'd had egg and had a reaction to egg that resolved with an antihistamine. So it's really important to have that information and can be really useful for us. So how do we test for food allergies? There are two main types of testing. The first is the skin prick testing, which many of you have probably heard of. And in this sort of method of testing, the allergen or protein is made up in a solution and it's introduced into the skin with a slight scratch, okay? It's a low-risk procedure. There is some discomfort, but it's actually quite minimal. There is no age limit to doing skin prick testing, which some people aren't aware of, but in a child less than 2 years of age, it is a specialist procedure and should be supervised by a specialist, okay? The other form of testing is your blood testing, and again, people are, I think, more familiar with this method of testing, and it actually measures the presence of those antibodies, so those IgE antibodies that we spoke of before, that are specific to different food allergens, and there's a whole panel that we can test for. It's not as sensitive a test as the skin prick test, so you may not pick up an allergy if it actually does exist, but it's recommended in certain instances, such as if a child is so allergic that they can't stop taking their antihistamine, or if they've got severe eczema, such that you can't interpret the skin prick test. So there's definitely a role for blood tests in these children. Managing your food allergy, just a quick point to say that sometimes your doctor, so your paediatrician or immunologist, may look at the trends of those skin prick tests or RAS tests over time to determine if a child outgrows a food allergy. So a number of the allergies that we've discussed, kids actually develop a tolerance to by the time they reach school age. So with your cow milk protein allergy, 80% of children by school age will have outgrown this allergy. A similar proportion, probably not as great, outgrow an egg allergy, less so your nut allergies. Only 20% of children will outgrow their nut allergy peanut allergy by school age. But it's something that your immunologist or paediatrician may follow over time. Obviously, the primary sort of way we manage these food allergies is with your allergen exclusion diet. And this can be very challenging, especially where there are multiple food allergies. And there are certain instances where we would be recommending that you see a paediatric dietitian. In instances where you've got 2 or more food allergens, an exclusion diet in these instances can be very difficult for parents. So a dietitian would be recommended. Also, if there's a need to eliminate an essential nutrient such as calcium, it's good to have a dietitian involved so that adequate calcium supplementation is given. If the child has poor weight gain, that would be another indication, or if you've got a child who's a fussy eater or difficult eater. The other thing that's really important in managing these children with food allergies is creating a safe environment, which is great at home because you've got control of that environment. But when your child starts going to daycare or to school or preschool, this can be very, very difficult. So it often involves meeting with the people at daycare, meeting with the people at school, seeing who's available, who has knowledge of food allergies for starters. Do they know how to manage a food allergy? Is someone at the school able to administer an EpiPen if the child has an anaphylaxis? So all this is really important to determine before you actually send your child to one of these institutions. Anaphylaxis, I'm not really going to talk about that much because it's a very rare reaction, and when it occurs, it's a medical emergency. And all children who have an anaphylactic response to a food or any allergen should be under the care of a specialist, okay? Adrenaline is the first line treatment, and it's usually delivered via an EpiPen, okay? There's a website, www.allergyfacts.org.au, which has the latest anaphylaxis guidelines for each state, so have a look at that, okay? I think we've got time to just quickly talk about food refusal, and the reason I put this up here was because a lot of parents come to see us and they say that their child's refusing food and could it be a food allergy, and most of the time it's not, okay? So many children go through phases of refusing to eat certain types of food or refusing to eat all food at all times, and it only becomes an issue, I guess, where the child is not thriving, so they're failing to gain weight, or where they're dehydrated because they have inadequate fluid intake. But most of the time it's part of the normal neurodevelopment of a child. They're developing their own autonomy, they're wary of new foods, they need time, okay? So take-home message is, if for short periods, it's not harmful, okay? Some tips to manage these children: obviously try to eat as a family, preferably at the table. Create a lovely environment where the kids can learn good social skills relating to food. Make sure it's calm and relaxed as possible if you've got lots of little kids, but with no distractions, so no TV or anything like that. Don't worry about table manners. Let the child help themselves to food, okay? Small portion sizes are better than large, and make sure that you offer rewards for positive behaviour, and that should be a non-food reward, because we don't want to see then the opposite happening when the child actually does start eating and you can't stop them. So to sum up, food allergy is a pretty common presentation in children. Most reactions are mild to moderate, but do present challenges to families, especially with their food exclusion diets. It's important to seek specialist medical advice when food allergy is suspected, to assist with the diagnosis and management, and often a paediatric dietitian is required in the care of these children. Okay, any questions? Yeah. Sorry? Okay, so I guess the question is, if a child has a cow milk allergy and goats and sheep's milk are not recommended, what do we recommend? I think it depends on the presentation of the child. So if the child presents maybe with a bit of colic or a little bit of vomiting, so it's a very mild reaction, and they're formula fed because they're on a cow milk formula, I wouldn't recommend the goat's milk or the sheep's milk, because the reaction will probably be the same to those formulas. So in that instance, as a first line, you could try this yourself, just one of the partially hydrolyzed formulas, so your HA formulas, okay? If the child presents with, the bloody diarrhea and then they're not thriving and they've got a suspected cow milk allergy, then I'll actually put them on one of the, more hydrolyzed formulas, such as your Pepti Junior. And interestingly, I've had a number of patients who have actually prescribed this recently and found out that, there's actually a shortage of Pepti Junior, and that's Australia-wide, and it's given us a real sort of problem in that I'll try a few of these parents on the HA formulas first, and if I'm still not happy, then I'll go directly to the amino acid formulas. If they're above 6 months of age, soy is a good option. Just to be aware, though, that there can be this cross-reactivity. So until we sort of sort out this issue with availability of Pepti Junior, I think you might be over-treating a few of these children with the elemental formulas, which then has its own issues, because you need to have a paediatric immunologist or gastroenterologist involved with the prescription of those formulas. So yeah, in that instance, that's probably what my approach would be, but it would depend on the presentation of the child and the severity of the reaction. If I thought that they had an anaphylaxis to cow milk, I would go straight to an elemental formula, the amino acid formula. Yeah.